Hi guys, welcome back. Now in this video module, we will learn about pneumonia. It is one of those topics which is crying for attention. And the reason I say so is because when you look at our own practice with respect to pneumonia, be it outpatient practice or inpatient practice, we really royally mess it up when it comes to prescribing the right antibiotics, or even our approach to management of pneumonia is kind of messed up. And I'm making it as a very generalized statement, though some of you might say that yes, I practice what is being prescribed or what is being recommended by recent guidelines, but it is not applicable to the general population at large. Most of the doctors are still practicing the archaic recommendations for the management of pneumonia. So in today's video module, we will, apart from learning what is essential for NEET assess, also we will focus on improvisation of our practice. Okay, let me begin by defining pneumonia. How do we define pneumonia? Pneumonia is basically an infection of the lung parenchyma. Infection of lung parenchyma. That is how we define pneumonia. So that means the alveoli and the intervening connective tissue and the pulmonary vasculature binding connective tissue is all affected in patients with pneumonia. Okay. And when we talk about pneumonia, we hear this particular classification of pneumonia as community acquired, hospital acquired, ventilator associated and healthcare associated pneumonias. And it is important for us to know the exact meaning of all these terminologies because it is going to influence the management. So let me begin by first understanding what is hospital acquired pneumonia. So if a patient develops pneumonia more than 48 hours after hospitalization, and if the patient was not in incubation at the time of hospitalization for that particular infection, it can be called as hospital acquired pneumonia. So that means the patient develops pneumonia more than 48 hours after hospitalization. Okay. Then what is ventilator associated pneumonia? If the patient develops pneumonia more than 48 hours after intubation, that can be called as ventilator associated pneumonia. Pretty simple. Same time frame for both. More than 48 hours after intubation. Okay. Then comes the question, what is this healthcare associated pneumonia? Let me tell you that the current edition of Harrison says that we should do away with healthcare associated pneumonia as a category because unfortunately this was initially proposed to help us identify the patients who are at risk of having multi-drug resistant organisms so that we can make a right choice of antibiotics. But this definition doesn't seem to help us in making that distinction. That is why Harrison says it's better to get rid of it. But sometimes examiners might still ask you questions based on that. So let us just define it. Okay, what is it? It's a kind of pneumonia where patient is not acquiring or he's not meeting these criteria for VAP or HAP. Okay, and he has history. So there is pneumonia which doesn't meet VAP or HAP criteria, and there is history of either one. There is hospitalization for more than 48 hours within last 90 days. That is one criteria prescribed. And the second thing you need to remember is within last 30 days, if patient had 2 or 3 important parameters. Among them, one is if the patient had IV infusions even at home. Okay. And the other parameter is if he had chemotherapy, IV infusions, chemotherapy, or wound care at home, or even chronic hemodialysis. If he has undergone any of these, chemotherapy, wound care at home, chronic hemodialysis, IV infusions in the last 30 days, or if he was hospitalized for more than 48 hours, anytime in the last 3 months, and such a patient presents with pneumonia, that pneumonia could be called as healthcare associated pneumonia. Okay. And the pneumonia that does not satisfy any of these parameters, HAP, VAP or HAP, will be called as community acquired pneumonia. So a patient who presents to you with some other complaint, but if his pneumonia becomes evident within 48 hours of hospitalization, obviously that will be counted as community acquired pneumonia, right? Or a patient who has no hospital contact, right? And then he presents with the pneumonia, that will also be obviously community acquired pneumonia. Okay, so this gives you an idea about what is called as community acquired pneumonia, hospital acquired pneumonia, healthcare associated pneumonia, and ventilator associated pneumonia. Okay, now let me also tell you some important points. Healthcare associated pneumonia, we really don't need to bother too much about it because Harrison says get rid of it. Now, HAP and VAP can be studied as a single entity because the bacteria which are responsible for HAP and VAP they are kind of similar. So it's the similar bacterial profile that we will see in patients with HAP and VAP. That is why we will be studying it as a single entity and CAP as a separate entity. Now overall CAP is more common, so we will start with community acquired pneumonia. Now when we talk about the organisms which are responsible for community acquired pneumonia, you have to remember that overall viruses are most common. Viruses are more common than bacteria, then obviously fungi, right? Fungi are least common. Okay. Among the viruses, it is the rhinoviruses which are most common. Rhinoviruses are the most common. This is a potential MCQ point. But still our concern is primarily with respect to bacteria, because bacterial pneumonia can be fatal. I am not saying that the viral pneumonias don't kill the patients, but at least bacterial pneumonia, acting timely and using the right antibiotic or the right combination of antibiotics can be life-saving. That is why focus is on the bacterial pneumonia. Okay. Viral pneumonia, as you all know, mostly it is going to be supportive. Now, among the bacteria which are responsible for the pneumonia, you have to remember that the most common bacteria for community acquired pneumonia is Streptococcus pneumoniae or pneumococci. Right? So, pneumococci are the most common cause for community acquired pneumonia. And for that matter, remember when you talk about children or adults, for community acquired pneumonia, it is the most common cause. Now, the bacteria that cause pneumonia can be classified as typical and atypical. The typical are the ones which are easily culturable using routine culture media. Easily culturable. They are very much easily identifiable on gram stain because they are extracellular organisms. On the other hand, what we call as atypical, they are intracellular bacteria. So they are not easily culturable, not easily identifiable on gram stain. And clinically also, the typical organisms cause a typical pneumonia which is clinically presenting in a different parameter, and the atypical, it presents in a different context. Okay, so the typical organisms include Streptococcus pneumoniae. As we all know, it is most common. Apart from that, Haemophilus influenzae, Staph aureus, Moraxella catarrhalis, and certain anaerobes. These are common typical organisms. Atypical organism, the prototype example is Mycoplasma. Mycoplasma pneumonia is a prototype example, and that is the most common among them. Then you have Legionella pneumophila, Chlamydia pneumoniae, and Chlamydia psittaci, which causes psittacosis. These are examples for the atypical pneumonia. I'm going to take you through some important MCQ points which can be asked straight out in your NEET SS, and then we will discuss more about the pneumonia. Community acquired pneumonia, overall most common cause are viruses, and among the viruses, it is, as I have told you, rhinoviruses. In terms of bacteria, which is the most common? Streptococcus pneumoniae, right? Yes, pneumonia is the most common organism responsible for community acquired pneumonia. When you talk about healthcare associated pneumonia, it is most likely methicillin resistant Staph aureus. This is according to the API textbook of medicine. Both the information that I'm giving you right now. And the hospital acquired pneumonia, most common is MSSA more than MRSA according to API textbook of medicine. But you have to always remember, the moment you start talking about the hospital acquired pneumonia or ventilator associated pneumonia, you have to think of two important additional organisms. Strepto, Staph, all that we have already discussed, those are known causes for even community acquired pneumonia. But once the patient is hospitalized and if he is developing pneumonia, either ventilated or non-ventilated, Pseudomonas and MRSA are two real concern. Though MSSA is the most common infection for HAP, MRSA is a real concern and Pseudomonas is a real concern. Okay, so these are important MCQ points. Now coming to the risk factors for community acquired pneumonia. Age is an extremely important risk factor, and under 4 years of age and after 65 years of age, the risk of pneumonia and associated mortality significantly increases. Both the risk of acquiring pneumonia as well as dying because of pneumonia increases if you are under 4 years of age or more than 65 years of age. And studies have shown that males are the ones who are at higher risk of developing pneumonias than females. So there is slight gender dichotomy here. In terms of comorbidities, there is a lot of comorbidities which increase the risk of pneumonia, right? I am starting with diabetes mellitus, which is an important comorbidity. Apart from that, chronic debility is an important comorbidity because chronic debility increases the risk of micro and macro aspirations. Then low GCS is a risk factor. Alcoholism is a risk factor. So alcoholism is a risk factor. Okay. Apart from that, stroke, and neurological diagnosis is a risk factor. These are all associated with increased risk of developing pneumonia. Okay, then occupation can be considered as a risk factor for certain infections, right? Not all, but for certain infections, occupation can be a risk factor, especially if you are working with poultry or bird farms. There can be increased risk of developing pneumonia. These are the risk factors. The important risk factor that I would like you to remember is the age. In fact, that is why we take age into account whenever we talk about curve 65, right? Okay, so these are about risk factors. Now coming to the clinical features, the way these patients are going to present. The most common presenting complaint would obviously be cough. Cough is the most common presenting complaint. Apart from that, these patients can have fever and systemic features in the form of malaise, fatigue, myalgia, right? Now these are systemic features that these patients can present with, and they can have dyspnea and respiratory distress if the patient is having severe pneumonia. And when we talk about cough, cough may be productive or non-productive. It could be productive or dry cough, and the nature of cough might give us some clue. Like, typically speaking, the dry cough is more common with atypical pneumonias, and the typical pneumonia is most likely to be productive. And the nature of the sputum might give us some clue, right? So sputum, though we don't see such a description from the patient side these days, because most of the time before they come to us, they would have been exposed to some antibiotic and then they'll end up in the proper clinics. So it is difficult to see the classical description of sputum, but at least for the exam sake, we should know. Sputum, red currant jelly, which infection it points towards? Right, it points towards Klebsiella. Right, it points towards Klebsiella. Similarly, sputum, which is rusty color, what does it point towards? Rusty sputum. What does it point towards? Rusty sputum can be seen in streptococcal pneumonia most commonly, but sometimes even staph. Right, staph and strepto, they can present with rusty sputum. Okay, then it could be purulent in any other bacterial infections. So these are the points from the sputum that you need to remember. Okay, now talking about fever. Fever is, like, you can see it in both typical as well as atypical, but fever and systemic features are more common with atypical pneumonia than typical pneumonia. More common with atypical than typical pneumonia. So in simple words, you can remember that when we talk about atypical, you can see them as systemic infections with lung involvement. So like lung involvement is part of it, but the whole system is involved. So that is why they have systemic manifestations. On the other hand, the typical pneumonias, you can simply remember them as primarily lung disorders, and the systemic involvement is secondary to the lung involvement. So that way you will know that systemic features are more common with atypical. Okay. Now these are going to be the clinical features. Just a quick distinction between typical and atypical pneumonia. Symptom wise, typical will have lung symptoms or respiratory symptoms predominantly. Atypical, systemic more than respiratory. On physical examination, the typical pneumonia will have identifiable findings. Right, so physical findings mainly focus or suggest that patient might have extensive crepitations, he might have bronchial breathing, okay, he might have agophony, he might have a whispering pectoriloquy. Now all these are suggestive of what? All these are suggestive of lobar involvement, right? So lobar consolidation is like a typical example of typical pneumonia, or sometimes you can have bronchoconstriction, right? But when you have a patient with lobar consolidation, we know that it is like very, very typical pneumonia. On the other hand, on the physical examination of atypical pneumonia, the physical signs and symptoms are going to be minimal. It will be kind of out of proportion to the respiratory exam findings that you would be seeing, and the complaints or the symptoms and the respiratory exam findings will be totally out of proportion. Patient is symptomatic, but you don't find gross examination findings. So max you would see is crepitations. crepitations. Okay, so when you image the patient, then you will clearly know. The imaging in case of the typical pneumonia would either show, as I have already told you, it will show lobar pneumonia or bronchopneumonia. On the other hand, in atypical, it would show often bilateral, patchy, alveolar infiltrates. Alveolar infiltrates. So all these dramatic findings that we spoke about, like bronchial breathing and agophony, whispering pectoral, all of that is typically seen when there is extensive lobar consolidation. When there is patchy alveolar infiltrates, you will not be able to see. That's why you will only see crepitations. So obviously in these patients, the physical findings will be so less in comparison to their symptoms. But in case of typical pneumonia, their symptoms and the physical findings kind of match. Okay, so this is typical versus atypical. Now that brings me to the investigation. A patient has presented to you with cough, either dry or productive. From the examination, you're suspecting that patient is having a respiratory infection, could be pneumonia. So what could be your initial investigation of choice? Probably you will start with chest X-ray, right? That is the initial investigation of choice, because when you say pneumonia, we know it is a disease of the lung parenchyma. So you have to prove that the lung parenchyma is getting affected. Otherwise, cough can be because of tracheitis, bronchitis, bronchiolitis. So you have to prove that it is the lung parenchyma that is getting affected. So you start with chest X-ray. So when you do chest X-ray, you might see various patterns. It could be lobar pneumonia, or it could be bronchopneumonia or diffuse alveolar infiltrate. So when you see lobar pneumonia, you know that it is typical pneumonia, right? So in this X-ray, you're seeing a lobar pneumonia, and tell me which lobe is affected here. This is the site of pneumonia. Which lobe is affected here? Is it the right middle lobe? Is it the right lower lobe? Or is it the right upper lobe? How do you identify lobar pneumonia on an X-ray? See, you have to remember that a definitive sign of consolidation on X-ray is what? Consolidation on X-ray is presence of what is called as air bronchogram. Air bronchogram. So look for air bronchograms whenever you have white opacity on the chest X-ray. If it is there, it is suggestive of consolidation. Now, how do we localize? The localization depends on what is called a silhouette sign, right? What am I talking about? Silhouette sign. So you will try to see the major cardiac markers or major surrounding structures, borders, which are being obscured by this opacity. That tells us which lobe is affected. Okay, so if the upper tracheal and esophageal shadows are being obscured by the white opacity, it is suggestive of the upper lobe involvement. So if there is an opacity here and I cannot distinguish between the opacity and the tracheoesophageal markings, right? It is like all merged into one. That is suggestive of upper lobe consolidation. Okay, if it is a right mid lobe consolidation, then you will not be able to distinguish opacity from the cardiac border. From the cardiac border, you will not be able to distinguish the opacity. And if it is the lower lobe consolidation, then you will not be able to distinguish the opacity from the diaphragmatic margin. So in this case, it is very easy to identify the diaphragmatic margin, but it is a bit difficult for me to distinguish the cardiac border. So that is why this is a right middle lobe consolidation, right? So if the tracheoesophageal markings are obscured by the opacity, upper lobe. If the right cardiac border is obscured, then it is middle lobe. And if the diaphragm is obscured, it is lower lobe. So in this case, it is right middle lobe consolidation. Okay. Sometimes X-ray might hold additional clues, not typically in adults, but especially in pediatric patients. You can see what is called as pneumatocoels, air-filled sacs that you are seeing here, pneumocoels. And this can be asked as an MCQ. Where do you see pneumatocoels? Pneumatocoels are typically seen in staphylococcal infections. Pneumatocoels are seen in staph infections. Staph aureus infections. So it is rare in adults, but in pediatric age group, you can see. This is one case report of a rare pneumatocoel occurrence in adults. Then third thing is, sometimes X-ray might have additional findings again. In this X-ray, what you're seeing is what is called as bulging fissure sign. So like how pneumatocoels suggest staphylococcal pneumonia, bulging fissure sign suggests Klebsiella pneumonia. Klebsiella pneumonia. So in the exam, the question will typically go like this: patient chronic alcoholic presenting with community acquired pneumonia, and X-ray shows this picture. So here you can see that it is the upper lobe consolidation, and this upper lobe consolidation, the interlobar fissure is bulging downwards like a convexity, right? This is what we call as bulging fissure sign. It is seen in Klebsiella pneumonia. So in the question, look for alcoholism as a clue, and the second clue could be red currant jelly sputum, and the third clue bulging fissure sign. In that case, you can commit to the answer Klebsiella pneumonia. Okay, so this is about the X-ray. Now in this X-ray, what do you see? You can see bilateral diffuse alveolar opacities. So this is a case of atypical pneumonia. It could be viral or it could be bacterial atypical pneumonia. Okay, so X-ray can help us to distinguish between typical and atypical. Now I'm going back to the previous slide where I was discussing about the other investigations. Now tell me, will you do sputum investigation for all the patients of community acquired pneumonia? Should you do a gram stain and culture or no? Okay, so what 2019 Infectious Disease Society of America guidelines recommend is that routine sputum gram stain and culture is not recommended for outpatients. So if it is a community acquired pneumonia patient who is being treated as an outpatient, routinely doing sputum culture and gram stain is not recommended. So if it is a severe pneumonia, it is recommended. If you are hospitalizing the patient and there is risk of the multi-drug resistant pathogens, then it is recommended. For the outpatients, it is not recommended. You just treat them with empirical antibiotics. Clear? So you don't need to do gram stain, you don't need to do cultures. So it is not recommended for OP treatment. So if the patient is fit to be treated as an outpatient, don't do culture and the gram stain. Okay. Then you can also do urine antigen detection for infections. Which infections can be detected using urine antigen? Yes, Legionella pneumophila, and Streptococcus pneumonia or pneumococci, right? These can be detected using urinary antigen. Now, what is the recommendation? The recommendation says no need, not recommended right now. But from the microbiological perspective, we should know that urinary antigen detection is possible for Legionella and Streptococcus pneumonia. Right now, it is not recommended. Okay, why it is not recommended? Because the current guidelines show or say that any case of community acquired pneumonia, hospital acquired pneumonia, ventilator associated pneumonia, all should be treated with empirical antibiotics. Though we know that majority cases are viral, the misdiagnosed or delayed diagnosis of bacterial pneumonia is a significant burden on mortality. So all cases of pneumonias should be treated with antibiotics until and unless the viral etiology is very, very clear, like in case of COVID. Otherwise, all cases of community acquired pneumonia should be treated with empirical antibiotics. Hospital acquired and ventilator associated pneumonia should also be treated with empirical antibiotics. Okay, so now if you have a patient of community acquired pneumonia in your outpatient or emergency room, how do you manage it further? The first decision we need to take is how do we dispose the patient? Should we send the patient home on a prescription of antibiotics or should we hospitalize the patient? So for that, we have two decision-making tools. One is Curve 65 and the second one is Pneumonia Severity Index. All of us are very much familiar with this Curve 65 because from our undergraduate days, we had been studying about it. But what recent, the 2019 Infectious Disease Society of America guidelines recommend is that they suggest we should be preferring the Pneumonia Severity Index. We should prefer the pneumonia severity index, and on the pneumonia severity index, if the patient belongs to class 4 or 5, such patients should be admitted or hospitalized. And if they belong to class 1, 2, 3, you can manage them as an outpatient. Okay, just because we've been following Curve 65 for some time, let us also talk about Curve 65. So like we all know, Curve 65 has the 5 components: age more than 65, then blood pressure less than 90 systolic or less than 60 diastolic, respiratory rate more than 30 per minute, blood urea nitrogen more than 19 milligrams per deciliter, and presence of confusion. Now, this is how we define Curve 65. If 0 to 1 points, there is outpatient based treatment. Okay, more than or equal to 2, inpatient based treatment, and again within this, if it is more than or equal to 3, ICU admission is what is recommended. Now books to books, this recommendation keeps changing because Harrison says 0 outpatient, 1 to 2 inpatient, provided that 1 is not coming from age. If age is the one which is responsible for your score 1, you can still treat it as outpatient if curb doesn't contribute any points. But if you have a patient where 1 point is coming from age and there are other points also coming from curb, then those patients can be treated as an inpatient. Okay, more than or equal to 3, ICU should be considered. Okay, now if you're treating the patient as an outpatient, obviously antibiotics are coming into picture. Then how do we decide which antibiotic to start? And is there any role for procalcitonin? Because we have been used to repeatedly depending on procalcitonin for making a decision about antibiotics. But again, the ITSA guidelines recommend that there is no role. The choice of antibiotics, whether to give antibiotics or not, all that should be a physician judgment or decision and not the procalcitonin based judgment. Okay. Now, empirical treatment is indicated for all patients, whether you're treating them as an outpatient or inpatient. If you're treating them as an outpatient, based on the curve or pneumonia severity index, first point is if there are no comorbidities present. See, comorbidities like diabetes do influence or do increase the risk of having significant infection, and the mortality is slightly on the higher side, and the organisms may be drug resistant. So we have to be a little cautious about prescribing antibiotics to patients with comorbidities. Those who do not have any comorbidities, what is recommended now is either you can treat them with a combination of amoxicillin or even ampicillin plus a macrolide, or second a combination of amoxicillin plus doxycycline. We are adding this macrolide or doxy mainly for the atypical coverage, because the emphasis is not on doing the gram stain and culture, which is not making much of a difference in terms of outcome. So we are relying more on making empirical choices. Now, the Harrison also gives you a third option, which is using a macrolide as a monotherapy. But in the Indian context, it is not valid, because even the Harrison says when the resistance to macrolides in the pneumococci is more than 25%, we should not be using macrolides. In India, most of the states report that the resistance is more than 25%. So that's not an option. So please do not prescribe an azithromycin or a clarithromycin to any of your outpatient with community acquired pneumonia. Either give them amox plus macrolide or amox plus doxy. Okay, and you have to remember here, the amoxicillin that we are using is without clavulanic acid, or if you're using ampicillin, without sulbactam, right? We are not using the beta-lactamase in this combination. But if the patient has comorbidities, if comorbidities are present, in such a circumstance, you are suggested to use with combination like amoxicillin with clavulanic acid, amoxiclav plus a macrolide is one option, or amoxiclav plus doxy is one option, right? So basically we are considering using the clavulanic acid in addition to what we prescribed in the no comorb group. Okay, I'll show you the table that is there from the Harrison. Okay, so no comorbidities or risk factors, then amoxicillin plus a macrolide or doxycycline. Monotherapy with doxycycline can be considered, I forgot to tell you, but monotherapy with macrolide is not recommended with Indian context. In Indian context, we cannot use macrolide as a monotherapy. And when you talk about with comorbidities, again, combination therapy is recommended, but it is like amoxiclav plus a macrolide or doxycycline. Or else you can consider a respiratory fluoroquinolone as monotherapy that includes levoflox or moxiflox or gemiflox. These are respiratory fluoroquinolones. They achieve higher concentration in the respiratory system. These can be considered as monotherapy for outpatient practice. Most of my prescriptions are focused on the levoflox these days, and you have to remember that if there's a risk of tuberculosis, that if you're suspecting that the patient may be having tuberculosis, or if you consider TB as a differential diagnosis for patient's pneumonia, in that case, please do not prescribe the quinolones, because it will hamper the bacteriological identification later, because quinolones have antitubercular activity, right? Okay, this is about your outpatient management. Now, if you are admitting the patient as an inpatient based on curve or pneumonia severity index, then you have to further classify those patients into severe pneumonia and non-severe pneumonia. Okay, how do you classify them into severe and non-severe pneumonia? It's a criteria which is there in practice for quite some time now. So there are major and minor criteria present. What are the major criteria? Presence of septic shock or respiratory failure that mandates mechanical ventilation. The patient is requiring intubation or he has developed shock. Those two are major criteria. So if there is one major criteria present, anyone, patient is in shock or patient is in respiratory failure and on ventilator, that is enough to call it as severe pneumonia. Or if there are more than or equal to 3 minor criteria present. Okay, what are the minor criteria? Respiratory rate more than 30, PaO2 by FiO2 ratio less than 250, multilobar infiltrates, patient confused, urea more than burn more than 20 milligrams per deciliter, WBC count less than 4K, platelet count less than 1 lakh, patient in hypothermia or patient in hypotension, but he is responsive to fluids. Shock is where he is not responsive to fluids, right? So if more than or equal to 3 minor criteria present, then also you can call it as severe pneumonia. So our approach to severe and non-severe differs. So if the patient is inpatient and if he is having non-severe pneumonia, mostly our treatment focuses on giving a combination of a beta-lactam antibiotics plus a macrolide. So this beta-lactam is usually an injectable. You generally choose an injectable beta-lactam plus a macrolide, or you can consider a respiratory fluoroquinolone alone, just like what we discussed now, levofloxacin, moxifloxacin or gemifloxacin. This is when you don't have risk factors for drug-resistant organisms. So if previously your culture had grown Pseudomonas or MRSA, like in last 1 year period, if you had a respiratory infection where culture had isolated MRSA or Pseudomonas, then we need to think of those organisms, right? So this is a table from Harrison that kind of summarizes. If it is non-severe and no risk factors, a beta-lactam plus a macrolide or a respiratory fluoroquinolone. But if there is prior history of respiratory isolation of Pseudomonas or MRSA, we need to add coverage for MRSA or Pseudomonas depending on whatever was isolated, right? If it was a Pseudomonas which was isolated, you have to cover or add an anti-Pseudomonal antibiotic. If it was MRSA, maybe vancomycin or linezolid. Okay. Then if the patient had history of recent hospitalization or recent antibiotic exposure, non-severe pneumonia according to the criteria, but there is history of recent hospitalization or recent use of antibiotics, especially within last 90 days. Now pay attention to what I'm going to say. See, when I said previously you had isolated MRSA or Pseudomonas, then you're definitely adding the coverage. You're not depending on the culture. But if there is only exposure history, like recently patient had been to hospital or recently has received antibiotics, and thus the risk of having MRSA or Pseudomonas is high, but in those patients, you don't empirically cover them. You will ask for culture, wait for culture. If culture identifies there is MRSA or Pseudomonas, only then you will add the coverage, right? Only then you will add the coverage. Okay. And based on the criteria, either having one major criteria of septic shock or respiratory failure requiring mechanical ventilation, or more than or equal to 3 minor criteria to call it as severe pneumonia. In that case, if there is no risk factors for drug-resistant infections or MRSA or Pseudomonas, then again the approach is very same. Beta-lactam plus a macrolide or a beta-lactam plus respiratory fluoroquinolone, even if it is severe pneumonia. The regimen is very, very similar. But if prior respiratory isolation, again approach is similar, you are adding coverage to MRSA or Pseudomonas. But if there is recent hospitalization or antibiotic exposure, here you are not waiting for culture. That's the main difference between severe versus non-severe. If it is non-severe and there is recent hospitalization or recent antibiotic use, then you are not waiting for the culture to start MRSA coverage and anti-Pseudomonal coverage. You are straight away adding both of those coverages. This is our approach to the severe pneumonia. Okay. Now coming to the approach to hospital-acquired pneumonia and ventilator-associated pneumonia. If you remember, I had already made a statement, whether it is hospital-acquired or ventilator-associated, the organisms responsible are very similar. So our antibiotic policy is also similar towards them. Okay. So if there are no risk factors for MRSA and significant risk factor of drug-resistant gram-negative infections, including Pseudomonas, in such cases, we will try to treat hospital-acquired pneumonias and ventilator-associated pneumonias with an antibiotic which, apart from the regular organisms, also covers Pseudomonas. That's our primary focus. So you can consider either using piperacillin tazobactam, cefepime, or levofloxacin. Okay, you can use it if there is no risk factor for multi-drug resistant gram-negative infections, mainly talking about Pseudomonas. On the other hand, if there are risk factors for gram-negative resistant infections, then the Harrison gives two tables. We have to use one antibiotic from this table and the other from the other. Basically speaking, we are trying to use two anti-pseudomonal antibiotics. Okay, so you can choose either piperacillin tazobactam, cefepime, ceftazidime, imipenem or meropenem as your one antibiotic. And from the other group, between amikacin, gentamicin, tobramycin and quinolones, ciproflox, leoflox, or colistin or polymyxin view, you have to choose one. Okay, so examination wise, they might ask you under what circumstances you would consider using two anti-pseudomonal antibiotics in a patient with hospital-acquired pneumonia or ventilator-associated pneumonia, right? So I just made a summary of the points you need to remember. Double anti-pseudomonal antibiotics are indicated if IV antibiotic use within last 90 days, which is associated with high risk of drug-resistant infections. If the patient is in septic shock, if patient has ARDS, or if there are more than 5 days of history of hospitalization before the development of ventilator-associated pneumonia, or there was dialysis or renal replacement therapy prior to onset of ventilator-associated pneumonia. In all these circumstances, preferably use two anti-pseudomonal antibiotics, right? Otherwise, primary focus is on covering Pseudomonas. If MRSA risk is there, you are adding MRSA coverage. Okay, so with that, I'm concluding my session on pneumonia. Do spend some time on trying to understand these antibiotic policies, because in one go it is difficult to understand. If you're first year, second year resident of MD medicine or DNB, I would say that what you learned today, go through the Harrison books again and put it into practice. That's the best way to remember the recommendations with respect to antibiotics. Now, next time if you have a community acquired pneumonia patient in OPD, use PSI or GERB65 to decide about hospitalization rather than deciding on intuition. That way you will be able to remember PSI and GERB65 very, very well, and then prescribe the antibiotic based on these recommendations, so that again, everything gets registered in your mind. I'm signing off, guys. I'll see you in the next video module with next interesting topic. Thank you.